For those of you who I haven't had the pleasure of meeting, I'm Sandro Galea, and I have the privilege of serving as Dean of the School of Public Health. This is we do this monthly around lunchtime, and this is coupled with our Public Health Forum, which is also monthly and usually in the afternoon. The Public Health Forum usually features somebody talking about academic work and developments in the field of science. The Dean's Seminars on Contemporary Public Health Issues usually features either a speaker or panelists talking about something that's very much on our minds. Today, I actually can't think of anything that's more on our minds than the topic that we're going to be talking about today. But I will let Dean Harold Cox introduce this. Dean Cox is our Dean of Practice, who is really the mastermind and organizer behind this series. Harold.
Hi, everybody. I'm very glad that you're here. Want to let you know about the next event that you should be thinking about and putting on your calendar. It's the Bicknell Lecture, which will be on October 19th. And this year, we're going to be talking about e-cigarettes, whether you're for it, whether you're against it. Good idea, bad idea. So please put that on your calendar, and you'll see, you'll see what happens. Today's presentation is incredibly important. Indeed, all of us have been thinking about the election, and we have also been thinking about health and health reform. And so our presenters are indeed people who are on the front line and have a very good understanding of this. This presentation really should be called Three Johns and a David. But let me give you just a brief piece of information about each one of them. John Gruber is down on my left. John is the Ford president of John is good. Ford professor of economics at MIT. He's been at MIT since 1992. He's also the director of the healthcare program at the National Bureau of Economic Research. In the years 2006 and 2012, he was rated as one of the top 100 most powerful people in healthcare in the United States by the Modern Healthcare magazine. John Kingsdale, who's next to John Gruber, is a professor of practice here at BUSPH in our Health Law Policy and Management department. In 2006, he was appointed by Governor Mitt Romney to organize and lead the Massachusetts Health Connector. After he left the Health Connector, he served as a consultant for other states who were attempting to implement the ACA. John McDonough, who is next to John Kingsdale, is a professor of public health practice at the T.H. Chan School of Public Health across the way over there. And he serves as we can't say the name of that place here. It's just not appropriate. He served as the executive director of Healthcare for All here in Massachusetts, where he played a key role in the passage of the Massachusetts Health Reform Law. And then he served as a senior advisor to Senator Kennedy and the Senate Committee on Health, Education, and Labor and Pensions, and was largely responsible for helping support and get passage of the Affordable Care Act. These are three Johns, and I'm going to put it in the hands of the David, who is Professor David Jones here in our Health Law Policy and Management group. Please give them a hand.
So thank you very much, Dean Cox, Dean Galea, for this opportunity. On my commute in this morning, I tried really hard to think of a good joke, like a 50s rock band or something like that, the David and the Three Johns or something, but that was great. So I just want to emphasize a couple things as we start. One is how fortunate we are and how excited I am to be a part of this panel. You got a sense from these introductions that we have three people who really played a very prominent role in the passage of the ACA, its development, its implementation, what a great opportunity this is to learn from them. Another thing I'll point out, too, is they all came from Boston. We didn't have to buy any flights, right? So that says something about the role that Boston and Massachusetts played in the development of national health reform, and I think that's really interesting, and look forward to talking more about that. One final thing I'll say before we jump into a conversation is ask the question, why talk about politics in a school of public health, right? It might seem like it doesn't fit, but my point of view, and I'm somewhat of a political scientist, so maybe this is my slant, but we spend so much energy doing research on what policies should be adopted, but often the policies that are adopted are more a function of the relationships between individual people and the conversations that happen over beer and pizza late at night, more so than the peer-reviewed evidence that gets produced. And so it's really important to understand the political dynamics and how that shapes policy. So we're looking forward to having that conversation today about the ACA, the election, what's at stake going forward. We're going to talk amongst ourselves for a little bit, and then we'll open the floor to some questions. So think about some questions. We'd love to hear yours. So to start, to understand what's at stake in November for the future, I think it's important to think about where we've come from, where we are now. So I'd love to have each of you reflect on your role in either the implementation or the passage of the ACA, and look back. And maybe the way to think about this is knowing what you know now about the policies, how they've played out, how the politics have played out. Is there anything you would have done differently going forward? So maybe we'll start here with John McDonough and work our way down.
Thanks, David. Thanks, Dean DeLeo, and thanks, Harold. And thank you all for having me here. I'm fond of this place. I was an adjunct here for 13 years and taught the class on health policy and politics. So have a lot of great feelings about this school and what you all do here and the people who work here and make their way through it. I'd suggest maybe instead of John, you Mo, Larry, and Curly might do well, you know. There are a lot of things that I would do differently about the ACA. In hindsight, there are things that I would have done differently about how it actually looked when it was going through passage. There were a lot of imperfections and problems and things that need working in the law. And I would also say that I believed then, and I still believe today, that the law that passed is pretty close to the best health reform law that could have passed the United States Congress in 2010. You could maybe tweak around the edges, but given the extraordinary political environment where the Republican Party decided very early on en masse not to collaborate, not to be part of it, and to require Democrats to either capitulate to an unacceptable reform law or else to give up entirely. It went about as far as it could. The access pieces, I think, to some extent are going as well, or perhaps even better than we might have expected, with the uninsured rate in the United States now down to about 8.6%, according to CDC and some other federal surveys. The 20 million Americans who now have coverage who didn't have it prior to the whole implementation period. The extraordinary amount of innovation and experimentation going on now in the healthcare provider community on health system transformation with accountable care organizations, bundled payment, readmissions, hospital-acquired conditions, so many elements of that law. And I think we really can say that we are seeing an evolution away from a dysfunctional fee-for-service system and toward a value-based payment structure that is still not entirely in shape and entirely visible, but I believe the movement is clear. And so while there are lots of things that I think any one of us probably would change, I think it's also important to recognize that given what we were all working with from President Obama on down, we got an awful lot done, and the work is hardly complete.
Thank you. John?
Thanks, David, and thank you for the introductions. I sympathize with what John's saying. I think has been very successful. I guess I have a little bit of different perspective just because I wasn't all that involved in enactment, but was much more involved in implementation and have been since then. And my mantra has become simplify, 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 which is something that probably nobody in Congress could give two hoots about or would listen, even if it was coming from somebody much more impressive than I am. And I'll give you an example of something that's been very difficult, needlessly difficult in the implementation. We had this sort of new policy toy called the Health Insurance Exchange or Marketplace, and we kind of overloaded it. It really, in Massachusetts, was an insurance store. And we actually took the most difficult part of the ACA, of Title I, which was a whole new eligibility determination system, which in Massachusetts, we simply outsourced to Medicaid. And fortunately, Massachusetts Medicaid was able to do a very good job with it when we started in 2006, 2007. And in the ACA, we kind of loaded, or Congress kind of loaded that on, without really a lot of thought, onto these new exchanges. Now, there are a couple of states where the state, some overall health agency or the Medicaid agency, which has been in place for 50 years, has taken that on. But by and large, that was given to state exchanges, an entity that didn't exist at the time, and that had one unicorn in Massachusetts. And so all these states have to create, and it took them years to create a new agency, which had to do the biggest lift in Title I, implementation-wise, which was determine eligibility for Medicaid and tax credits under a whole new set of federal rules, all of which had to be worked out. And that, I think, has been the crux of the IT problem that the exchanges have faced. It's not that it's hard to set up an insurance store. We set it up in Massachusetts literally for a $2 million IT budget, capital budget. We ran it for $1 million. The hard lift was the whole new eligibility determination system. And unfortunately, we just didn't think it through. We put it on a non-existing agency that was just finding its feet rather than one that had been doing eligibility determination for 45 years. And that was a huge problem. That was the IT bust that we all went, the glitches, so-called, that we all went through. And they are still working them out in the states, as you know.
Excellent, thank you. And before I turn over to John Gruber, one thing I forgot to mention about his bio is he has written a comic book about health reform, which is pretty impressive and cool. And I didn't believe it the first time I heard it, so I ordered it on Amazon. I have it in my office if anyone wants to come borrow it. It's actually pretty great. So there's a plug for you, John.
Thank you. Thanks for the plug.
Yeah, and stop laughing so loudly. You're really disturbing the rest of the faculty.
I agree very much with both things that were said by my esteemed colleagues here. I think that I want to come back to something John McDonough mentioned, which is the best you can do given the constraints. It really frustrates me when people complain about the Affordable Care Act not accomplishing X, Y, and Z, not appreciating the constraints it was under. And one of the most important constraints I want to emphasize on, given the role I played, is the constraint of honesty. Okay, when Lyndon Johnson wanted to do Medicare, he knew it was going to cost 5 to 10 times what he said it was. He just lied and just, look, it's going to cost this, let's just pass it. And they did. And we all love Medicare, and that's great. But let's be honest, it's not a good way to make policy. Okay, we were under unbelievable truth-telling constraints enforced by one of the most underappreciated assets of the U.S. government, which is the Congressional Budget Office, which actually made sure that we're bipartisan, nonpartisan party making sure that the numbers added up. And, to be honest, it's part of what sunk Bill Clinton's healthcare reform in the early 90s is the CBO called him on some bullshit he was trying to get through, and it didn't go through. And in this one, so what is amazing about Obamacare is not only is it a great law, not only has it been successful, it was done so honestly, at least as honest as we could given the projections we could make. Now, those projections have turned out not to be so bad, despite everything you're hearing. For example, the primary projection was that we'd cover by now about 25 million uninsured people. We've covered 20 million, and a bunch of states that were supposed to expand Medicaid haven't. So actually, CBO is pretty right on the nose on that one. What have they gotten wrong? Well, they've gotten wrong the fact that the exchanges are much smaller than we thought they'd be. Why is that? Well, it turns out about 50% of it is because employers haven't dropped insurance like we expected them to. Actually, and that's kind of good news. About half of the exchange shortfall is that employers haven't dropped health insurance. So that's sort of a projection that got wrong, but sort of on the good side at some level. Now, you might say, but didn't get premiums totally wrong. Look at these huge premium increases. And here, once again, is where the press is misleading. No. Premiums after this year shakes out will be about exactly where CBO projected them to be in 2017. You might say that's impossible given all the news. Well, what the news didn't tell you was the 2014 premiums came in 15% below what CBO projected, and the 2015 premiums didn't grow at all, where CBO projected a 5% growth. So in fact, in terms of premiums, we're right about where we thought we'd be. It's just it took the politically disadvantageous cycle of good news at first, bad news later, which never works politically. But in fact, the premiums are not, this is not a disaster on premiums. They're where we thought they'd be. However, once again, I think we come to, I think it's important to John McDonough, the ex ante versus ex post perspective. So given the way we set it up ex ante, we told the truth. The numbers are working pretty well. What we didn't factor in, I think much at a higher level than what John Kingsdale was talking about, is just there's never been this kind of concerted, engaged effort to undercut a law that was the law. I mean, my sense of the way politics works is you fight, the law passed, you shake hands and move on. That's not how this law's worked. Okay, the fight got more heated after it passed. Indeed, within the first few years, I think something like 30% of Americans hadn't known it had passed. They thought it still wasn't the law. And that has been a headwind that no one anticipated. That's part of why things have been difficult. I think, for example, the US government could not pass critical regulations to set up the exchanges till after the 2012 election because of all the politics around Obamacare. So that slowed down getting things in place. I'm not sure it would have worked anyway. So I think the law was set up right. I think it's achieved the goals that we thought it would achieve, but I think no one anticipated the incredible difficulties we'd face politically and the resulting troubles that have arisen.
And one of the challenges about the political realities in the Senate particularly maybe, were that the states ended up having to play a very prominent role in the implementation, right, which precipitated and led to all those political challenges. And the reality is getting a law, getting something passed in a state like Mississippi is just very different than doing it in a state like California that has really extended the politics far beyond Congress. But I want to pick up on this thread that a few of you talked about. Ask the question of, is the ACA succeeding? The coverage expansions, are they working? On the one hand, President Obama is writing viewpoints, I think it was in JAMA or New England Journal of Medicine, calling this a huge success. Donald Trump campaigning, calling it a huge failure. Insert however many U's you want there, a huge failure. For some of the reasons that you've already kind of addressed, but I'd love to hear other people on the panel respond. Is the ACA working?
So I would say it is working. It has stresses and problems and challenges, and it could be working significantly better if there were a will in Congress to come together and do basic, not very complicated stuff to improve the functioning of the law. For example, in 2 federal programs in Medicare, Medicare Advantage, Part C, and Medicare Part D, the prescription drug program, there are 3 common insurance mechanisms referred to as the 3 Rs, reinsurance, risk adjustment, and risk corridors, that are part of those 2 programs, that have always been a part of those programs, and will always be, and are really essential functions that make those markets function and work. The ACA, for the first 3 years of the marketplaces, included included all 3, 2 out of the 3 leaving, but there's been this immense political fight, particularly Marco Rubio and other folks who've been saying it's an insurance bailout, but it's an insurance bailout in the ACA, but it's not an insurance bailout in Medicare. And if, in fact, those had been allowed to work, we would probably not have seen the collapse of the co-op plans that we did to the extent that we did. We wouldn't be seeing a lot of the desertion of the markets from so many of these carriers. So there's a lot of fairly simple stuff that the public doesn't understand at all. When they're asked in a poll, do you think it's good to have a big bailout of the insurers? Of course they say no, but they have no idea what we're talking about. We're talking about risk adjustment or those kinds of things, because those are just insurance industry lingo. So I think there are simple things that could be done across the board. We've got to get to a point, and my hope is that we'll get to this point next year where Congress is actually willing to start to come together and focus on the things that we can do that will really fix the law and make it even more aggressive in achieving its potential and achieving the kinds of changes that I think most Americans want to see.
So actually, to pick up on your question, has it worked? I think it's been extremely successful. I mean, we haven't quite got the coverage we wanted, but close to it. And As John pointed out, if Texas and Florida would just join Medicaid, we'd probably be at 25 million, join the Medicaid eligibility expansion. I don't know whether it's probably better to be lucky than smart, but the ACA can claim credit for not having busted the greatest flattening of trend in health insurance and healthcare spending in the last 30 or so years, and well, last 20 years since the mid-90s. So we've not seen healthcare costs grow. In fact, actually spending on the ACA has been far less than the CBO projected. And there's some very interesting, there's clearly some quality improvement that's being initiated. You can see MACRA recently enacted earlier this year as really an endorsement of all the payment reforms that were being piloted with the ACA. So I think there's a lot of good stuff that we've achieved. We've helped a lot of people, frankly, in this country. Politically, it's been, as you've heard, and as everybody knows, incredibly unsuccessful. The fact that Republican opposition has really not changed in 5 years, 6 years, is so strong, is amazing. Now, fortunately, we're not hearing quite as much about it in this election, and I hope...
as long as Bill Clinton keeps his mouth shut.
Yeah, and we hope maybe that'll be put to bed, but I think that's the greatest failing, and I'm not sure that was anybody's fault, except that, again, I'm going to come back to this thing that nobody else cares about, simplification. Mm-hmm. There are about 10,000 people, literally, out of 320 million Americans who actually understand anything about the ACA. And I've been working on it for 10 years, or 5 years, and I continue to get questions from states. I haven't the foggiest idea what the answer is. So you can imagine how this just glazes over. I mean, most Americans don't even understand what an annual deductible is, let alone any of this other stuff. If there was some way to make it as simple as, if you like your health plan, you can keep it, which got them into a lot of trouble because it wasn't true, but actually make the mechanisms more transparent and understandable. I think that might be the salve for the political wounds.
Someone should really do a comic book.
Yes.
So I think I'm an economist, so when you ask if it's successful, you have to say relative to what? And I think if you say relative to anything that's in the real world, it's been incredibly successful. I mean, literally, it's covered almost everyone's supposed to cover. It's done so at premiums that are about where they were supposed to be. It's been under budget. It is, I think, at least bears some of the credit for slowing the cost of healthcare growth, not most, but a little bit. I mean, it's been incredible. But the problem is that's not the standard.
What about that job killer?
It's not the standard it's being held to. The standard it's being held to is, did it fix American healthcare? Right. Well, let's be honest about this. American healthcare will never, ever, ever be fixed. Okay? In fact, healthcare around the world will never, ever, ever be fixed. As long as healthcare exists, all developed countries, all countries will struggle with controlling the cost of healthcare. It doesn't go away. It's just a question of, can you deal with it? And the answer that we pioneered in Massachusetts, the ACA did is, well, look, that's a hard, long-run problem. Let's at least get everyone in the system, and then we'll work on slowing the costs. That's what the law tried to do. I think on policy front, it's been unambiguous success. Mm-hmm. Politically, it's been unambiguous failure. And I think that is just really, it's frustrating to me. It represents, in some sense, how complex it is, despite it is a 150-page comic book. It is a complex law. I think, to be fair, to rebut you a little bit, John, every time you sit down and say, couldn't make it simpler, it's like, well, yeah, but you got to do this, this, and this. Mm-hmm. It actually, John McDonough was involved with actually putting pen to paper more than I was in the actual law. It turns out to be hard to do these things simply, okay? But I think the simplification was less in the words of the law and more in the implementation should have been done more simply. But I think it's, by any realistic standard, it's been unbelievable success. And I think Trump, when he says it's a failure, all it is point to random numbers, and none of which have any basis in the real world.
Yeah, so when I get asked this question, I often quote Frank Thompson, who's a political scientist, he wrote a book way back in 1981 about implementation. And at the end, he ends the book by saying the way we should judge success of an implementation of a law is not whether it solves every problem, like John said, but whether it leaves us with a better set of problems than we had before, which I think, in my mind, the ACA passes that test. It's a better set of problems than we had before. So let's transition to talking
Can
about.
I just add
yeah,
one
please.
thing on this? John touched on it. I actually thought that, and here I'm going to contradict myself a little bit, but I actually thought that the ACA was overreaching in trying to control healthcare costs. You know, here in Massachusetts, there was a head fake on healthcare cost containment in the 2006 legislation. And basically, we've had 3 enactments since then, 8, 10, 2012, all trying to deal in a fairly superficial way, eventually a little bit more in depth in 2012, with cost containment. But that's really hard. I mean, you know, talk about politics. Cost containment for a legislator means getting a reduction in pay or firing people who save lives for a living. This is not how you win re-election. And I thought the ACA and the Democrats were incredibly bold and brave to truly try to take on cost containment at the same time as expansion of coverage in the ACA.
When people ask me, you know, how do you feel the law says, I say on coverage, we did about 90% of where I want to be. On cost control, we did 125%. I never thought they could get the elements of cost control, like the Cadillac Tax, which is an incredibly powerful cost control device. And economists have lobbied for something like that for 50 years. And to get that in the law, I thought was incredible.
Do you have any insight, John, on kind of having been on the inside of the conversations around some of these elements of why deal with both at the same time to the extent that the ACA does?
Because the stakeholders demanded it.
Okay.
The business community, labor, drug companies, hospitals, everybody said, consumers, everybody said to us, and they came to us in our offices, and they always would wag their fingers. They say, don't you dare do what they did in Massachusetts, which is just do access and not address the glaring, amazing inefficiencies and waste in the system. And then we'd ask them for their ideas, and we'd send all the ideas down to CBO. CBO would come back. We called it the wall of zeros. You know, it saves nothing. Thanks for your ideas, folks. So what we did was kind of, you know, I don't know if you've ever done any what they call skeet shooting. You know, you put something in the little catapult and you goes up in the air and people shoot at it and stuff. So we took every idea that the stakeholders had and we put it in the catapult and we shot it up in the air and all the stakeholders shot at it and everyone that didn't go got into Title III of the law.
That's how laws get made. Yeah. So let's transition to talking about the election now. And so given this world that we're living in, kind of the ACA world, Donald says it's a huge failure. Hillary, I think, is arguing to build on the success of the ACA. What have you heard from either candidate about what they would do if they were elected in office? And then we'll pick it up from there. But I'll open up to whoever wants to comment.
So November 8th will not be decided by what's going on with the ACA. What happens to the ACA will be decided by what happens on November 8th. So this is like 2014, like 2012, like 2010, an enormously consequential election in terms of the fate and future of health reform. If you take them at their word, take the Trump health plan, and take Paul Ryan's plan that was put out in, I believe, August or early September. They are both committed to complete, total repeal of the ACA. A lot of people say, oh, they can't do that. Oh, they don't really mean it. I don't know how many times they have to say it before we take them at their word that they really mean to do as much as they possibly can and use the budget. And Paul Ryan, I believe, just said today or yesterday that if Republicans hold the White House, the House, and the Senate, they will move a budget reconciliation vehicle to dismantle as much as they can out of the ACA and to do $1 trillion in tax cuts as well in the same vehicle as rapidly as possible early next year. The estimates of the Committee for a Responsible Federal Budget are that the Trump agenda would lead to a reduction of about 21 million people losing health insurance by 2018. And the Ryan plan, of course, is not put in any kind of language where you could do that evaluation, but it seems fairly close. On the Clinton side, it is not abandoning or deconstructing the ACA. It is moving to advance, strengthen, and fortify the law. The estimates on Hillary Clinton's proposals are increases in coverage anywhere from 500,000 to as many as 9 million by 2018. So really a stark difference in terms of our health future. Neither side would be able to achieve everything that they want to do, and it really will substantially change the conversation depending upon how the world looks on November 9th.
Either of you want to add something on what
Well,
they are saying
just
or what they should
that
say?
there's a third possibility, and it may be that the electoral constellation after November 8th will favor one of the two options that John described, or it could be a third one, which is that there will be a repeal and replace legislation, assuming that Trump is in the White House, but that there's a very, very slim Democratic or Republican majority in the Senate, that will be more sort of tokenism than real. So it'll repeal a few things. John, we were talking earlier, mentioned the employer mandate, certainly the Cadillac tax, some of the more painful pieces of it. There'll be some reduction in funding. Retrenchment on Medicaid and encouragement of states to go back now that as 2019 advances, they might be responsible for as much as 10% of the new eligibility funding, and sort of a reduction in force, if you will, but not, and a claim of political sort of revolution, and some real hurt, but not a fundamental abandoning of it. And I think why that may be realistic is that this is America's biggest business. This is 18% of our GDP, and everybody in it has sort of transformed very painfully over the last 6 years to try to accommodate this incredibly pervasive element of funding our healthcare system. And now to sort of undo all of that would be extremely painful, including to very many vocal constituencies who are powerful within the Republican Party as well. So I actually think that may be more realistic than what Paul Ryan wants, but we will see soon.
Yeah, I mean, I think in the catastrophic case of Donald Trump winning, that, I think I'm much more where John Kingsdale is. I think, it could be fortuitous that the employer requirement is called the mandate, because then, as I said at lunch, Trump could say, I've repealed the employer mandate. And, everybody like, oh, we got rid of the mandate, isn't that great? And then, we could basically repass the law as it is without the employer mandate and claim victory. So it's just, there's too many people who are benefiting too much. If you're a party that's beat up Obama for 8 years on saying you can't lose your health insurance, you can't then take health insurance away from 20 million people. So there's just too much at stake for it to really be, and I agree with John's numbers he's citing, there's too much at stake for them to really just get rid of the ACA. I just don't see that happening in any way. I think you'll get some, they'll get rid of some window dressing and call it victory. I think under the better case of Hillary Clinton winning, then I think it really depends on, quite frankly, what you can do by executive order, because I just don't see the Republicans control at least the House. I don't see them being really inclined to be nice about things about the ACA for at least the foreseeable future. So really it's a question of kind of what she and her clever lawyers could figure out what to do through executive action to make the law better. And one thing, is can we try to remind people there's a mandate out there, by the way, you're supposed to have health insurance. Can we do better on advertising, do better administrative things? But I think, honestly, if Hillary wins, I think we're closer to the 500,000 than the 9 million, to be honest, in terms of what it does to coverage relative to the ACA baseline. I don't see what she can do without congressional support that's going to raise coverage meaningfully, which is okay. The law's doing fine. I think the most important thing to raise coverage is just to get the states to expand Medicaid. And my hope there is that getting the person who's the namesake of the law out of the Oval Office, even if he's replaced with another Democrat, will allow states some cover to actually expand Medicaid. So these states have had such their own. I mean, as an economist, the thing that's been the professionally most devastating to me about this is I feel like I can't teach politics anymore, because if I can't teach in a world where states would turn down this much money to help the most vulnerable citizens. I mean, it's so against any self-interest of any politician ever that it's just, I just don't know what to make of it. So I just got to think that if you get the namesake out of the office, maybe that'll ease the tension a little bit, and a couple of these states at least will come along and start to expand Medicaid, and that's the best thing that can happen for coverage, I think, realistically.
I think that might be true if the Democrat taking office wasn't named Clinton, as I said before, and that complicates the politics there.
And we should just mention about this issue, there were 3 states that accounted for about 30% of the uninsured in this country. One's California, which has expanded Medicaid and has signed up literally millions of uninsured. The other 2 are Florida and Texas, which have not, and they could well expand if they saw that the ACA was not going to go away.
Yeah, so my last question before we open up to the audience is about this point. I think there's about 19 states that still haven't expanded Medicaid. What will it take to convince those states to expand Medicaid? Hillary Clinton says she wants to incentivize, whatever that means, more states to expand Medicaid. One of the ways that conservative states have been expanding Medicaid is by passing waivers, where they say we're going to basically do something conservative. We're not going to call it Obamacare. We're doing it the Arkansas way. We're doing it the Indiana way. And in some cases, there's some substantive differences. Other cases, it's mostly symbolic. But states are pushing the envelope on how much they can get away with, adding work requirements and other elements to these waivers. So what will it take more states to expand Medicaid, and how far should a Democratic president bend on what Medicaid is and what they accept in these waivers?
So I think there's a fundamental value question here between the opposition to Medicaid and the support for it. And the value question is, do you believe that there is some form of a right to health care in the United States? And I think that there's a fundamental line, and the folks who have agreed to expand Medicaid in, say, the Arkansas, the Indiana, the Michigan, those kinds of states are sort of saying, okay, there's a right, but we want to limit then some more what it is. I think the fundamental right now, the biggest line between the two is the issue of a work requirement. And the desire by conservatives in the 19 states to say, the only way we will let you expand is if we only provide it to people who are working and not to people who, for whatever reason, cannot work. I think that's a fundamental political line. I don't see I wouldn't see a Clinton administration ceding that line, because that would then open up all different kinds of changes in a very difficult way. So I don't see it happening. I think that in next January, if it's clear that the ACA is not going to be repealed in the subsequent 4 years, I think we will see a loosening in a lot of states starting to migrate. I think it's worth remembering that Medicaid was established in '65. The last state that joined Medicaid was Arizona in 1982. So there's a precedent for states taking their time and working through this. And so I think that they will work through this. I would predict that by 2020, I think most states will be part of it at that point, because it's just going to get less and less tenuous. And in no state is there any pressure letting up from hospitals, from physicians, from insurance companies, from business to say, why are you folks not doing this? This makes absolutely no sense.
I couldn't have said it better, and the good thing is that John will be able to go back to teaching politics if that happens.
I have nothing to add.
Okay, sounds good. So let's open it up to questions and see what you have to say. We have 2 students with mics walking around. So if you have a question, go ahead and raise your hand. Yeah, Professor Mariner.
Hi, I have a question about the Cadillac tax. And you suggest that whether realistically it will survive. It was a success from the financial point of view. And it is a reason, I think, that a lot of employers are shifting costs onto their employees by means of having a different kind of health plan or higher deductibles or wellness programs with financial incentives or penalties. If the tax goes away, what does that do to costs, and what does that do for employees? Or how realistic is it that the tax would stay or go?
David, do you have a soapbox I can stand on? So there may be spies to the American Economic Association in the room, so I have to give my card-carrying economists. And no, seriously, let's just remember what we're talking about here. The U.S. has a system where if MIT comes to me and offers me a $1,000 raise, I take home $600. If MIT comes to me and offers $1,000 on orthodontia benefits for my daughter, I get $1,000 on orthodontia benefits for my daughter. So I get her the braces that change colors and spin, and they're super cool and all that. Because why not? It's free, and this is a fundamentally broken system. And the one meeting I was in with Obama about the healthcare law, we sat in the Oval Office, 6 economists, and he said, what can we do to control healthcare costs? And the only thing we all agreed on is this is a fundamentally broken system. We have to go after this. The Cadillac tax is the politically most feasible way of addressing this. So let's be clear, the Cadillac tax is removing an existing ill-advised tax break. Okay? Now, I understand politically that doesn't help, but we're all adults here. So let's recognize this is not a new tax. This is removing an existing tax break. And it's had enormous benefits. If you talk to every large employer in America, they're aware of it. They've changed their healthcare plans generally in good ways, take advantage of moving to more value-based networks. In some cases where employees weren't paying anything, finally making employees pay something for healthcare, which quite honestly, for the average union employee, they can afford it. Okay, these union employees making $80,000, $70,000, $80,000 who are complaining about a $20 copay. America spends 70% of our economy in healthcare. It can't be free to people. It just can't. People who can afford healthcare have got to pay some for it. So I think it's been an unambiguous step in the right direction. I think it's been, we may disagree about how much credit the ACA gets for the slowdown in healthcare, but I think the Cadillac tax itself has made a meaningful dent in the growth rate in healthcare, having not even been implemented. Now the question is, what happens? Well, there's two views. Remember that every year we delay, it gets more and more costly to get rid of it. Because the Cadillac tax, the money it raises rises exponentially because it goes with the cost of healthcare. So every time we delay, it gets more expensive to get rid of it. On the other hand, we did eventually just get rid of the doc fix. So the question is, will it end up in a situation like the doctor fix, where basically every year we delayed putting something that's painful for doctors and finally just repealed it and put it in with some vague stuff about other things we do to make doctors behave? And the question is there a solution like that for the Cadillac tax? Or eventually, will it be so much money it's going to be hard to just get rid of it? I hope the latter, but I honestly don't know.
So the irony is, of course, is that I believe every employer would agree with your statement that they've all seen it as giving them an outcome that they would like to see. And it's also true that every major business group in the country is advocating for repealing the tax right now. And of course, the Republican Party is in Congress is united in repealing the tax.
As is the Democratic Party.
At the same time, not everybody, not all the Democrats.
Yeah.
At the same time, though, Paul Ryan and the Democratic leaders in Congress are advancing, but we need to cap the employer tax deduction, not indicating that the Cadillac tax is actually its first cousin. And
right.
If you get rid of the Cadillac tax and you lose the opportunity to do anything else, and you open up this whole battle again. So it's a great case study of politics and economics coming together in dysfunctional ways. And the contradictions are just all over the floor on it.
I mean, once again, another thing that's hard teaching, it's a law that got passed where the only people for it were economists. It's sort of amazing. We're not that big a voting bloc, so it's sort of amazing it got in the law, but it's also been why it's been hard to get it implemented.
Max Baucus wanted it.
Yeah, Max Baucus wanted it for a while.
Wanted it, the Senate Finance Chair.
But it is...
He was under the influence of Jean LaBrue, though.
Yeah, but I think that basically, John's right. If we could trade it for a more rational... Actually, I'd prefer to trade it. There is a better way to do it, but that doesn't solve, the people will still be mad about that too.
I was having a conversation just earlier this week with the new guy who runs the Washington Business Group on Health. He said every employer's against it, and I said, so what do you put anything in its place?
Right.
And he said, well, we can't agree on that, and so it's just kind of so I would argue, if I had to bet money right now, I would bet that it's going to get repealed probably next year.
I hope you're wrong.
So my favorite solution, which nobody will like, is actually extending the employer tax break to individuals so that we at least...
I knew you were hitting Republican.
and helping them afford some to buy insurance on their own. Frankly, I think that would be better than doing nothing and simply repealing the Cadillac tax. Because there are, for all the perversions and the subsidies, of course it's not as big as the middle-class mortgage subsidy.
Actually, it's 3 times as big.
It's bigger.
Oh, it's bigger?
Yeah, it is bigger now.
Oh, I thought
yeah.
it was.
It's 250 billion a year because it gets the payroll tax too.
Oh, okay.
250 billion a year. The mortgage subsidy is
I
less
take
than
it back.
100.
I always read mortgage was the biggest. But it's certainly, if you look at somebody who is trying to buy insurance on an exchange and paying a fair amount of dollars in the 250 to 400% FPL or above range, not being able to take a deduction for that is a huge disadvantage. And frankly, I think it's not a bad thing to subsidize access to health care. Now, unlimited subsidies are the problem, not the subsidies to begin with.
Great. Thank you. Yeah, please.
Yeah, hi, Rich Sates. Can you speculate on the implications of the election for addiction and mental health care services? I mean, there's been, I know what ACA has done in some expansions, but I've heard talk from Republicans about using mental health as a way to solve, let's say, firearms as a health issue. And so there's maybe some support for mental health care. On the other hand, I don't know if that's real or what it really means. So anything about implications of the election for those conditions?
Yeah, I think, so I wrote a piece for the Millbank Quarterly a couple of months ago where I talked about, how should we view this bipartisan kumbaya on mental health and substance abuse, on behavioral health. And I think a lot of it is phony, I really do, because when you say you want to repeal all of Obamacare, and in particular, and they're not serious about everything, but one of the things they are serious about is Title I, and particularly one piece of Title I which lists the 10 essential health benefits that have to be part of every insurance policy. And one of those lines is, one of the 10 essential health benefits is coverage for behavioral health. So we have now created a benefit guarantee for behavioral health treatment that the Republicans want to take away, which has resulted in tens of millions of people getting access to behavioral health services who didn't have it before. You take it away, guess what? It goes away. So there is an enormous amount at stake, and it's one of many areas where there are enormous benefits, ancillary benefits to the ACA that are almost thoroughly unrecognized by the broad public. And behavioral health, mental health and substance abuse is absolutely one of those compelling areas. I'll just add another thing that's really fascinating about the ACA that I don't think any of us saw happening. Maybe you did, John, because you're so good at this. But there's been an enormous change in correctional health in the United States because of the ACA, because correctional institutions in the 31 states that have expanded Medicaid are now aggressively moving. Before you leave a correctional facility, you are signed up for Medicaid in that state. You leave the prison and you walk into a care system with mental health, with chronic disease issues, and an entitlement to be able to get those taken care of. And so Washington State is kind of the poster child for this. Their recidivism rate, since they have started this really aggressive effort on on getting people signed up, is their recidivism rate has gone from mid-60% down to below 20%. And they credit it because of this change. Some extraordinary stuff. Those are just two of the things that are going on that are very much at risk for what's going to be happening.
John, I didn't see that coming. That's a fascinating fact. But actually, I think this is a very important question the way you posed it, because it comes to what I said earlier. Do we compare the ACA to a perfect world or the real world? Yes. Has the ACA done everything for mental health that advocates would like? No, not at all. Is it unambiguously better than what came before and double unambiguously better than what the Republicans have put in place? Yes. So I think we cannot let the perfect be the enemy of the good here. You have to compare it to what the alternative is, and it's way, way better.
Thank you very much. Yeah.
You said that a lot of the questions about the ACA will be clarified with time. I'm wondering if there are questions about the ACA that we could answer now but haven't.
Well, I mean, I think we're still learning. I mean, maybe that's one way. So, for example, I've just done some recent research. I think one thing we didn't expect was there's been a huge what we call woodwork effect in Medicaid. So if you look at the Medicaid enrollment, despite the fact that a number of states haven't expanded, Medicaid enrollment is still exceeding expectations of CBO. And the reason is because, and I've done work with Ben Summers from the Harvard School of Public Health to look into this, people who were previously eligible for Medicaid are coming out of the woodwork. as they say. We're going to get a huge increase in people who had an entitlement to public health insurance, either weren't aware or had too much stigma or whatever, and they're now getting that coverage. So that's a new sort of thing we're learning recently we didn't know. I don't know if that kind of answers your question. I'm not quite sure. Maybe you could just suggestions the way I have in mind.
You know, it's interesting on that point, the penetration rate. I mean, we're still dealing, except for Medicare, with a voluntary health insurance system. Somebody has to voluntarily decide they want to take on the most boring, tedious, consumer unexciting purchase of their lifetime, and one of the most expensive ones. And we have penetration rates, even where it's free, as in Medicaid, as low as under 30% of the eligible population in some states. And of course, states have actually actively used disenrollment and redetermination as a budget vehicle particularly when they're facing tough times. So we've had the fortunate circumstance of all this publicity and outreach around getting covered, the mandate, and probably some folks who wouldn't be penalized still don't realize they wouldn't be penalized because they're not have enough income to qualify to be penalized for not having coverage, and an expanding economy during the last 5 years, all of which has, I think, resulted in a huge increase without any changes in eligibility in the Medicaid sign-up rates. But there's so much more to do. You know, the folks who are eligible for tax credits, the penetration rates are as low as 40 and 50% in many states of the uninsured who are eligible for tax credits. So one of the things we may find out is how do government, and I don't want to use the word, how do government employees, and you can all think of the derisive Republican way of phrasing that, how do government employees learn to sell health insurance? I hope we learn how to do that in the next couple of years, because we haven't quite figured it out yet.
I'd just say one group that we know has been unambiguously helped in a positive way and supported by the ACA is the community of health services researchers.
And consultants.
And consultants. This is full employment for health service research community. It's the gift that just keeps on giving, and I don't see any sign of it letting up.
Excellent. Thank you very much. Yeah.
In some of the exchanges at the county level, there's a growing lack of competition, and the term public option seems to be creeping back into the dialogue without much definition. Do you see anything coming along that looks like, smells like, feels like something called a public option?
You know, do you want to go ahead?
I'll say, I mean, so there's two. First of all, it's what do you mean by it?
Yeah,
There's a lack.
totally.
So if you're talking about a federal public option, that would require an act of Congress. I don't see that happening. What Hillary Clinton is saying is, well, let's use the state waiver authority, section 1332, and allow states to set up their own public options. If, and I guess my reaction to that is, yeah, that'd be great. But if you could tell me a governor in his or her right mind who in this market would like to go in and say, we are going to set up a state health insurance plan that's going to enter this marketplace, they'll get a little bit of applause on day one. And then for as long as it exists, they're going to get boos and cheers. Every premium increase is going to be held against them. How are they going to pay for the financial reserves that are necessary to set up an insurance plan? Are they just going to have it paid by premiums? Are they going to use state? It is a political nightmare, and I can see any and every governor of either party running from a public option in a state like the plague. I may be wrong, but I just don't see it for the life of me. What governor in his or her right mind would want to do this?
Well, you know, to build on that, if you're a Republican, you probably don't think it's a good idea. And if you're a Democrat, you made a political career out of bashing insurance companies. So to go into that business and compete with them, unless you're stupid enough to think that it's actually easy to rip people off, you know, would be foolish. But it's sort of ironic that, well, two other comments. It's a little bit ironic to think about the public option as a response to the shortage of health plans, because nothing will drive the remaining health plans out of the market sooner than the realistic prospect that Congress might do anything along those lines. The other is, I think we've seen, this is one of those things where we have totally asymmetrical news coverage. We don't have any stories about Molina or other national publicly traded Medicaid health plans going into new states. We have only the withdrawals in May through August of national health insurers who are very poorly positioned to be the most price competitive in their local markets, because they typically have low penetration of the local market. Yeah, they may be able to negotiate hard against the drug companies because they have a national market, but Aetna, United, Humana, they have no sway in Boston. They get like a 2% discount off of Partners because they don't have any people here. They're puny compared to Blue Cross or Tufts or Harvard or Network Health or BMC HealthNet. Those are the plans for which the exchange, which is very price-sensitive consumers, I mean, they really are shopping on every penny. Those are the plans that can expand and do well. And you actually want a market to punish the poor competitors and reward the efficient ones. So I'm probably Pollyannish. There will be some counties that are left underserved, but I think on the whole, we're going to see, I'm sort of bullishly central democratic on this. I actually think we're going to see the market respond, insurers respond to the opportunity of, even if it's only 10 or 12 million lives. That's the first expansion of commercial health insurance in 30 years. So I can't believe they're just going to leave it alone.
Let me just add one last quick thing, which is reflecting on this, reflecting once again generally on the debate. It's incumbent on the experts, of which we are a small share of the experts, but unfortunately a large share of the experts on this topic, to argue with facts, not anecdotes. Okay, yes, Aetna left, but as John pointed out, other people came in. What do we care about? We care about the number of plans and what's happened to premiums. What's happened to premiums is they're still at about where we expected they'd be. In aggregate, the number of plans is not that much lower than we thought it would be. The headlines get dominated by stories about one insurance company leaving and not 6 others coming in. And I think it's incumbent on the expert community to get beyond the debate of anecdotes and move to debate over facts, which I think the ACA wins hands down.
But one of the areas we were wrong was we assumed that most states would absolutely insist on having their own exchanges.
Right.
And it turned out to be, now we have about 13 or 17, depending on how you count those ones in the middle. The interesting thing is that the states that set up their own exchanges and the states that embraced the law and said, let's do everything we can to make this succeed, are doing markedly better than the states that were actively resisting, passing laws saying we won't let navigators function, passing laws saying the individual mandate is unconstitutional, passing all kinds of laws to try to guarantee the failure of the law. And those are the states that are having the biggest problems right now. Right. And so it's really, it's a little bit of be careful what you wish for, because you're just getting it. And I don't think a lot of those people care to see the markets failing. Yeah. But it really does require a partnership with the state, and where the states have done that, there's been a really much greater level of success.
Right. So as David and I have discussed in connection with the excellent book he's written on state resistance to the exchanges, I think one of the things we've learned is a whole new, I'm not sure it's new, but certainly far more robust political tactic. It turns out not only is it difficult to enact legislation, but there is, between the courts and the states, if you rely on the states for implementation, an entirely open field of guerrilla warfare against any legislation that has to be implemented that is complex in its implementation. And the job that the opponents of the ACA have done in the courts and in the states at undermining implementation, and even in purple states like Illinois, making it just too dangerous for Democratic legislators to embrace something as radical as a Heritage Foundation initiated idea of a government-run marketplace. Even there, it's just politically too risky for them. And so we've learned, I think, a whole new strategy for resisting the federal government.
Yeah, which I hope makes for a really good book. So shameless plug next summer. Look for that. Please join me in thanking the 3 Johns. It's been a fantastic conversation.